let's do 216 page. So there is another approach of treating this problem, headache. Remember, Mulligan doesn't diagnose. He tries a technique to see if you can modify symptoms. So can you modify or cause the descending inhibition, desensitize to myosin? Remember from the research, most likely the segment that is involved is C1-2 in clinical practice. Yeah. Now, what Mulligan does, so he tries three approaches when the patient comes with a headache. So you immediately can try these techniques. So they come with a headache. Well, you've done all your screening, you've done your 5Ds, 3Ns, 1A, no red flags. You know, it looks like it's a mechanical component to the headache. All right. And so the first one we can try, the technique that he tries is headache snag. HA snag. Okay. Sustained. So snag is sustained natural apophyseal glide. So sustained natural apophyseal glide. So what he does, so he pushes, I'll show you how, on C2 and holds that position for 10 seconds. And after 10 seconds, he asks the patient, how are you feeling? While I was pushing, was it any better? And if he says yes, it was actually easier, or the headache was reducing when you were holding the pressure, then we can hold for up to a minute, have the rest, up to a minute, have the rest, and we do that until the headache completely subsides, disappears, or maybe plateaus. So maybe it was 7 out of 10, you reduce to 3 out of 10, but no change. That's enough then until that day 1. So first we try headache snag. If the headache snag does not work, then what we can do reverse headache snag. So it's almost similar to instability, that's what we did yesterday. So we're going to hold C2 and we're going to bring the head forward. I'll show you, don't need to worry about it. I'm just going to explain it for the techniques. I'm going to demonstrate that. And then again, 10 seconds, patient feels better. Then repeat this the same way. For a minute, have a rest, a minute, have a rest, or 40 seconds or 50 seconds, until you're basically tired. Then to stop, have a chat with the patient, and again, keep going until either the headache completely resolves or plateaus. And if headache snag did not work, or reverse headache snag did not work, then we can try upper cervical traction, okay, in supine. Principle, exactly the same. So this is the order. What I do find clinically, that headache snag I get the most benefit from, or traction, maybe less so with reverse. But maybe some people can argue, maybe, you know, so I find that the headache snag can work really well for patients with cervicogenic headache, or upper cervical traction also be quite lovely.
If you 10 seconds, is it 1 minute?
Yes, so it's like a test, 10-second hold. If they have a good response, then you continue. If it doesn't, or it clears them up, obviously we're not going to use it. Remember, Mulligan should have an immediate pain change, immediate response, so it's a pain relief technique. If it doesn't, then this approach is not indicated. And you follow those simple rules, you can never make the patient worse because you're respecting, making sure, you know, so yeah. So it's a pain relieving technique. You will know in seconds if that approach is indicated or not. Alright? Okay guys, so let's have a look at those techniques around here.